Good afternoon, good evening, colleagues, ladies and gentlemen. Welcome to APOA Hand and Upper Limb webinar. I'm very happy to have you all here today for special course of revision shoulder surgery. We have wonderful faculties throughout the Asia. Now you can see two prominent eminent shoulder leaders, colleagues, ladies and gentlemen. Korea, who is
Welcome
Professor
to
YONG,
APOA
and the other from China mainland, Dr. Cui. I'm
very
going to
happy
moderate
to
this
have you all
webinar
here today.
We have a
for
full faculty
special
members, outstanding
course
shoulder
of
surgeons,
revision
Dr.
shoulder
Chanakarn,
surgery.
Dr. Teruhisa Mihata, and Dr.
We have wonderful
Sang-Jin
faculties
and Dr. Ashish
throughout
Gupta.
Asia.
All these speakers
can see
will enrich your knowledge and share their experience with you so that you can provide Professor YONG healthcare to your other patients.
China mainland, Dr. Cui.
Today, the program
here today
is going to run by two moderators,
outstanding,
and these are four top channels which has been chosen by a scientific committee member.
We have
revision surgery for shoulder instability, all this, and revision surgery for rotation, and revision surgery for shoulder arthroplasty. Is going to be covered one by one to your other patients.
China mainland, Dr. Cui.
Today, so the program, if you have any questions, moderators,
outstanding,
and please leave your questions which has been uploaded in a chat box so that our two moderators can present surgery and have more interactive discussion at the end of the surgery for rotation. So you are very warmly welcome to our area. He's going to be here. I would like to introduce our two moderators,
Dr. Cui,
Professor YONG, as you can see here, is the pioneer and leader of Korean Shoulder Society. Please feel very active participation practice, and Professor Cui, Institute of Sports Medicine and Aging University, is going to run this webinar. So you are very warm. So I would like to introduce these two moderators to you all. To be here, I would like to introduce two moderators and Dr. Cui, Professor YONG, as you can see here.
Thank you. Thank you, the President introduction. I'm YONG from Korea. I have the moderator from China, GUOQING, and we have four speakers. I think it's a very good session. Deep surgery for the shoulder, but not easy to manage this kind of problem. But we have very excellent speakers. Thank you, Chanakarn from Thailand, Neeraj from Japan, Sang-Jin Shin from Korea, Ashish Gupta from Australia. So China, we invite them, and we have presentation since the beginning. We will discuss. I think it's a very good session. Deep surgery for the presentation, but with not easy to 10 minutes discussion. So I just introduced four speakers. Three will discuss. First is the Chanakarn from Thailand, surgery on the shoulder. So China, we invite them come up and start with a presentation.
Good afternoon, friends and ladies and gentlemen. Thank you, Professor Lee and Professor Chui, for very nice introduction. And hi, Mr. President Jeon. Thank you for organizing this. Now I would like to share my slides. Okay, give me 1 minute to share my slides.
First is the Chanakarn from Thailand,
1 second. Oh.
China, we invite them come up and start.
Okay. Got it now, friends. You see it now, right? Thank you, Professor Lee and okay. First, my topic will be elevation surgery for shoulder RE-DISLOCATION. Thank you for organizing this. I start off my talk with one of the case that I saw. The nurse, 34 years old, just fell arthroscopic back cut twice. She just dislocated her shoulder when she was 16 years old from playing volleyball, and she dislocated again. 6 years ago she had first repair, and 1 year ago she dislocated again, just pushing the door, and it's re-dislocated again. She was referred to me for organizing this. Well, she slightly limit axial rotation. It's purely ankle instability and some sign of slap lesion. And this is her X-ray. See some evidence of the old ankle. What should we do? When she was 16 years, there are a ton of procedure that you can choose on. She dislocated again. Before you do that, you ask yourself, why that procedure? And 1 year ago, she got the etiology of the failure. The most common is sufficient energy to re-dislocate the severe trauma. That's the most common. The second one is the surgery to make thorough. The third one is early diagnosis and some signs. I start off with this one, early diagnosis. See, because why this is diagnosis is early. If it affects the decision, a ton of choose the wrong procedure is going to fail. And these are the factors that related to the recurrence after the back cut occur. But if you look at all the literatures together, there are four major factors that related to a fair arthroscopic back cut. The incidence is about 5 to 15%. The first one is younger age, and the second one is contact or collision stenosis. And the third and the fourth one are the bony lesions, either on the glenoid or the heart lesion. And these are our cases. Well, pure-operated, you see that patient have some to the glenoid body defect. You can see the blunt thing there. And obviously you have something at the circulation as well. So what's the lights to right surgeries after south? So then we need to re-evaluate the patient. Look for the sign of the general ligament laxity. And the third abiding score, bony lesion. Look for the possible missing pathology such as the Hacker lesion or tan propagation. You see that you evaluate the bone loss. Usually you look for bone glenoid body defect, hair circulation. And I personally use on factors the lights. So CT 3D is a gold standard. And using the crop base and for the base circle method, and usually calculate the bone loss on the glenoid side. If the elevation of the hair sac interval less than the glenoid tract, this is what we call on-tract lesion. If the hair sac interval bigger than the glenoid tract, this is what we call off-tract lesion. I think most people here know about CT 3D. So then you ask whether that case have a surgery taken place or not. This means that procedure was done on bone loss. These are the risk factors in the arthroscopic back cut repair related to the first, not enough angst. misdiagnosis of the Apoa region. The third is suboptimal repair, no bump effect, suture failure, or insufficient retention of H&UL. So when all the risk factors being evaluated, ask whether that case have a only thing that we don't know is the quality of the console level tissue. I will talk about that later. So come back to our patient's risk factors X-ray. So we do this CT scan and we see the glenoid bone loss is about 21% of the Apoa region. The health sac interval is 22.73 millimeters. So this is an off-track lesion. So in this case, this is the bone is the problem for the cause of the failure of arthroscopic articular. So to repeat the substitute procedure probably not a good idea. So we have to look for all those options of the bone procedure. And the algorithm for the arthroscopic articular. We have some clinical bone loss and the patient have not engaged or no health sac. This is not big enough, like a contract lesion. You can do RHEE. But if the patient are very active, like a competitive or contact athlete, you might think about ROTATOR. Or patient have engaged or fractal sac lesion. So to think about the region arthroscopic recovery plus or ROTATOR. When the patient reaches bone loss more than 25%, this is what we using for a while, right? More than 25%, go for ROTATOR if the area. We know that the protocol do not replace the glenoid surface if the lesion is more than 30%. If more than that, it's like those allograft or express bone graft. But if you look at this paper in 2020, like they think about they evaluate that if the patient have a glenoid bone loss more than 15% of surface area, not the diameter, surface area, and 25%, this is what we using for a while, right? Okay. The odd ratio of having dislocation is up to 3 times higher than the groups that have less than 50% of the surface area. So the threshold in my hand is come down to only 20%. In our case, the glenoid bone loss is 21%. It is off-track lesion. I think the best procedure for this patient is bone augmentation reconstruction, which can I choose ROTATOR in this case. Okay. So this is just I think people know this procedure. It can be done arthroscopic or open 50% of the time. I still believe that most of people in this world do the open ROTATOR procedure to identify the glenoid, clear. You refresh the glenoid, clear the breathing bone. This is very important because you want it to heal augmentation, and you make the screw fracture to the articular surface. Okay, and then you repair all the capsule level and the people know this procedure back. This is her at 10 weeks. Now she brought for 6 months, a month, a few weeks ago, and she never dislocated her shoulder again. So this is her post-op film. What you really want, you want the cohort process to align with the articular surface, no prominent or not too far medial, and you make the screw. So even the ROTATOR still can fail. You place the graft to medial or to lateral, or you have osteolysis of the graft. Or patient have a very significant bone loss. Of course, ROTATOR is not 100% guaranteed. The patient will not RE-DISLOCATION. I think the incident of the recurrent was so important. Somewhere between 3 to 6% will do a ROTATOR process. So, but if the patient have very big defect, like this case, obviously you need some bone to reconstruct the medial. Usually, you have no option. This is tibial allograft or the RHEE. But in some cases, this is a 37 years old with epilepsy. This is a chronic dislocation. Both bilateral shoulder dislocation. The glenoid is not too bad, but sometimes you get a big humeral head defect like that. You can address the bone defect on the humeral head like this. And this is the gate that I treat him. So I found that from my practice, I think to treat the defect on the humeral side. The femoral head allograft, which I borrowed from our trauma surgeon from the femoral neck fractures. The deep fry fits very well in most of the femoral head defects. So basically, I just measure the size, put the bone in, and fix them with just like a small standard cancer screw, and I bury the head of the screw down to some bundle, and then I repair. And since this is the chronic case, so I did the target on top of that just to. I like the idea of the sling effect to prevent the re-dislocation in chronic cases. So the post-op film looks like that. Very well in full stay, head defect. So basically, and he did. This is what the size, and we put the bone. This is and fix them with small standard. Yeah, somewhere there. Skills and down to some bundle. So any room for rebank surgeries. This is of course if you have the subcritical bone loss and non-engaging and full saturation. I like the idea of the sling effect to prevent the re-dislocation. First of all, I will not redo what I think I have done well. If I think it was a good bank repair at the very first time, and it's still dislocated, if this is my case, I won't redo it. But in this group, do you think some surgical bone loss or bone loss less than 10%? So the patient is not much. I think sometimes we have some room for the single rebank loss. But this is one thing we really don't know is the quality of the tissue, capsule label tissue. So we went in sometime to see the first of all, one of the capsule. So this is a good study from Sang-Jin. Yeah, if you compare the good one and the good one has the chair, and it's still which is a capsule chair, and the second one is a retain from the label chair. So he found that the good of the capsule chair, so the dislocation is up to 40%. So in my hand, if I had to do a rebank when I went in, I see the capsule chair, not a good tissue, I would not hesitate to convert them to target without hesitation. It's a good study from Sang. So rebank heart, compare the big one. Tip and trick to do a good rebank heart. First, you need the tension free release, and the second one is many times you go in an arthroscopy, you see you say, oh, there's no capsule, it's gone. This you cannot. It's almost empty. This is with caution about the absolution. Actually, what happened is here into the neck of the penis, see the capsule. So what you want to do, you want to switch your arthroscopy to the anterior superior. So it will work now. Okay, anterior superior portal, and you look at the tension sphenoid neck like that, and you many times you go in and the bank cut knife to release them. You really want to release them far down to the neck of the absolution of the neck of the sphenoid. The good thing if you can see the subscapularis muscle fiber, that's ideal. Usually sometimes it's bleeding, but it's okay. I like that because this is an adequate release. So you start to see the superior, the subscapularis muscle there. You see that. That is the good release. Many times you go in and look it from the anterosuperior or transcup portal. This is good. You really want to release them. So when you release it good, you see that is how well you can mobilize the tissue. But that you see a lot of laxity of the tissue. Now it's to drop subscapularis tension of the usually sometimes. So you get good mobilization of the labral. Then in my hand, this is how I do it. I emphasize on the number and location of the anchor. I insist at least 3 anchor, and the location is very important to me because we want to do a label and capsular check from the inferior. So it's like so my way. I put my very first anchor at 530 with the horizontal mattress. Why? Because you see there, I could put the anchor there and double load it. When I do horizontal mattress, which I catch the tissue from the posterior portal. When I pull up the capsule, it's like an inferior capsule itself. And the rest is just vertical mattress just to create the bump and effect. So what is the difference? mattress. This is the model that I use all vertical mattress. You will see just a few turns, and anchors are start move around the island. So I don't think it's as solid as the horizontal mattress. This model I use the horizontal mattress for the inferior anchor. See that? So it's like the inferior the horizontal mattress for the inferior anchor. It hold the tissue better than the vertical mattress. Vertical mattress is in my hand. See, so by doing that, with the primary, not the reducers, I have a 6% failure rate with one horizontal vertical mattress. We reported in the AP Smart Journal. I use the horizontal mattress. In the case that have the laxities, I would add the fourth anchor. I will do the 7 and the 530 anchor first. That should retrieve all the inferior capsule to try the mattress. So by summary, I think fair and stability is a difficult challenge. So what you need to do to re-evaluate the patient is look for the factors young, sport, velocity. I usually do both MRI program and CT, the construction to URL for the basic pathology and the fourth anchor. Procedure selection. If the glenoid bone loss, my threshold go down to 15%. I go for lactasis. But if glenoid bone loss more than 30%, I consider allograft like distal tibia. Patient with subcritical bone loss, which about 10 to 15%, and other factors. If they are very active overhead or contact area, I believe lactasis is the procedure of choice. But there's no risk. Patients who can go for arthroscopic pancreatic repair still risk of about 10%. But if patient have bone loss less than 10%, good quality labor to go for arthroscopic pancreatic repair. And last but not least, look at the humeral head. It's not engaged or on-track lesion to treat it alone. Smaller lesion, you go for precise procedure for an engaged lesion or on-track lesion. But if you have very large lesion, I prefer allograft, in which I use the humeral head for allograft conservative repair. Thank you very much for your attention. But if patient have bone loss less than 10%, good quality labor to go for
I think this is instability, but we have looked at the and so I think that this is time to have a discussion with Chanakarn. There's some one ask relaxed. Everybody, when you check the on track, off track, and calculate the percentage, the defect, I think you don't think about the fact that the patient has a bruise on accident. I think that this is time to have a discussion with the patient.
Well, this is very difficult question to answer because I believe all the on-tech and off-tech study has been done in normal shoulder. But if patient have on-tech and off-tech which laxity, those parameters could be changed, and this is very difficult. So what I would do, I would use intraoperative decision and consider the is still engaged. I would do more titration in the posterior answer because capsule, like adding the 7 o'clock anchor sometimes, and also doing our lepiside. But the patient that put the anchor, the stitch more medial to hold the infraspinatus and down to the this is very difficult just to prevent more exaltation. That is, I usually use intraoperative evaluation, intraoperative decision, and consider the still.
If there's any question,
I would do more titration in the answer because capsule doing adding the 7 chart patient like sports lepiside. But the patient that put the anchor,
yeah, when you decided to do what kind of procedure for this patient, what do you see the most important factor, like the sports participation or defect
Here's
of
a
the
question.
I think both are important, but if they are about the same defect, in my hand, most of my cases fail when she go back to play volleyball, badminton. Because this is it's the same story now. They dislocate their shoulder, and it doesn't matter how good you repair, it will be as good as the one you born with. So when they play, they stress on that. So they will eventually fail repair. So I don't know if it didn't heal or it just hold with all the sutures. I think so. In my hand, each patient do overhead fairly. Sometimes I discuss with them well. You want to go for lethargy, and I do like your suicidal operation. I haven't done it honestly, but I like the idea that you use the tendon and to prevent even sometimes you do the good banker repair, and augment with just the tendon, just to prevent just the anti-stabilizer to prevent just a weak tear. I think that is not a bad option for the overhead athlete like that. That's my thought. Sometimes you can share. So you're the best in terms of the arthroscopic suicidal operation. What do you think about that? I like the idea that
in my case, I think more than 90% of dislocated discs are flexible. So if we just do like the first time the first time dislocation, they have no defect undislocated. There are two reasons. One is the body is really weak.
What do you think about that?
Against the kind of space, something like this. The other is the sports tire. They put the end. So if we just do like at the abduction, the first time dislocation, and the capsule defect, the capsule of the anterior part of the femur. There are two reasons. One is not enough for this kind of sport. So think about that. If we do this procedure, if the patient the sports like to return to sport like basketball, so if we do like so if you do just a bank card and the capsule enough, not the capsule of the anterior part of the femur. There are two reasons.
Because you should look in all the European, you go there, like they have a big meeting in shoulder instability.
Think about that. If we
March, most Europeans they're only talking about lethargy. They talk about if you want arthroscopic bank repair. We can have a topic of is there any room for arthroscopic bank repair? But in my hand, it's up to who's the patient. Many of my patients they not that active, and they like the procedure that simple, small wound, potentially less constipation, which is arthroscopic bank repair, and they do accept the failure rate at 10%. So some of them accept that. It's a matter of you well discuss with the patient. The patient accept that, well you still can find bank repair. But if patient very high expectation or have very high risk of re-dislocation such as the bone loss or they like high demand or contacting alley, well might potentially the lethargic position, which is arthroscopic repair.
Okay, we have to talk about the principle for the audience.
It's a matter of
we know the Ortho is really good to decide the choice, but we have to think about the risk consideration, like laxity of comprehension, and second is the activity, the injury or mention about that, the child thing. So this physical examination, the patient has a lot of things, even though the patient has only subcritical, we know the Ortho is less than 10 degrees over 5, it's 5 degrees, the choice, 5% also. We have to think about very depends. We can think about the bony procedure or the procedure. Anyway, the thing is on the object, but we have to think about another thing, another side. That is a good idea for the decision to have energy I have a very good question for Chanakarn. You use a cancer screw for the procedure, but the European recommend the screw, but I used to use only conventional screw 3.5. But why I give up the cancer screw? Sometimes it's for
well, I most of my cases I use the cancer screw or candidate screw because I feel in my hand it's okay and there's not much complication. But what I worry most nowadays that a lot of company come out with like a bottom and use a suture and to tie up and compress the bone block. And that sometimes, the drill hole to pass the bottom and there's some micro-motion between the suture and the hole. So I would worry if you can use those, like what do you call it, the bottom on both sides. I still like the screw. So I use the tensor screw.
Okay, we have 2 minutes left. There's one more question. If the cancer is vaccine, what do you do? Any augmentation?
Well, like I mentioned in the beginning, the drill hole, I even plan to do arthroscopic rebank side, and I went in and see the crack capsule is so bad. I just go ahead and go for Latate procedure. I would not risk the second failure for the patient, but this will be advised to the patient before surgery.
This is the last question. If patients are asleep, and because the hydration is stability, how can you manage it?
Well, this is what the picture in the drill hole.
Any kind of patient, because stability, but he has a stiff shoulder.
Stiff shoulder for the patient, but this will be advised. I don't see that. Usually they are really loose. I have limited experience for answering that question because most of my RE-DISLOCATION cases they are quite loose. Well, I see some in the elderly people that they have a cuff tear and RE-DISLOCATION shoulder. If that's the case, I would look for the cause of RE-DISLOCATION, whether the patient has associated cuff tear in the elderly or not. But in the young, I have limited experience to answer that question. I don't see that. Usually they are really loose. I have limited experience for answering that question because most of my RE-DISLOCATION they are quite loose.
Their case is instability because of stability with the stiff. So I asked them what is the choice, but there is no answer. But I've done that open back here with the stiff relief. So we can do the early motion because we can expect some adhesion after the open back repair. So that is my choice. Some of them after the procedure they have shoulder because a lot of tension. So in this case, I've done very, very early rehabilitation. There's no answer, but I've done that. Thank you, Chanakarn.
Thank you. I will put the remaining question in Q&A box. Okay. Thank you. Bye-bye.
Bye-bye. You stay there.
I'm free.
Next is Teruhisa Mihata from Japan. He talked about the revision surgery for the rotator repair, failed repair. Yeah, SCR again. So good. Welcome.
Thank you, Dr. Ray. Actually, my talk is I'm sharing my slides here. Can you see?
Yeah.
Okay. Again, yeah, thank you very much for inviting me there this APOI webinar. So my talk is a revision H&UL for rotator cuff repair. Here's my disclosure. So as you know, arthroscopic rotator cuff repair, so maintain rotator cuff repair integrity has been correlated with improved outcome. So to prevent the rotator cuff repair, so around 10 to 20 years ago, repair technique was developed. First, rotator cuff repair is performed using the single row repair technique, but afterwards, double row suture brace was developed. Then it's 15 years ago, biochemical study shows the suture brace technique provides stronger fixation than single row, double row techniques. So now I think most of the shoulder surgeons using the suture bridge technique for rotator cuff repair. But here's the return rate of the rotator cuff repair last year. Still, it's very high, 6.2 to 38.1%. Actually, this number has not been changed for last 10 years, even though the repair technique developed and any augmentation technique developed by this literature did not change. So we need to think about how to treat repair patients and how to prevent repair after rotator cuff repair. So here first, how to treat the repair patients. I'm using the H&UL using autograft fasciolata. Actually, for revision H&UL, maybe you should use autograft fasciolata. This is it's a very strong graft material. Dermal graft, maybe you cannot get good outcome because too elastic. So definitely I recommend autograft fasciolata for revision H&UL. Here is our result, and the revision H&UL graft tear rate, actually 23.5%. For me, it's very high because the primary H&UL is 3.5%. So still, we need to think about how to prevent the graft tear for revision H&UL. And the ACS score here, it's improved after H&UL 27 to 79, but it's not good. It's not excellent, 79, because the primary H&UL is a 94 after surgery. And after elevation, it's the revision H&UL improved 69 to 127, but again, it's not excellent because the primary 155. So revision H&UL is worse outcome than primary H&UL. And this result is a healed patient, a graft failure patient after revision H&UL. Healed patient, it's better, of course. ACS score improved 27 to 82, but improved, but again, it's not excellent because 82. But graft failure, it's improved, but still 68 after surgery. Just they get the pain relief, so that's why score increased, but the function did not improve very well, so only 68. And after elevation, his patient increased to 75 to 144. 144 it's not bad, but for me it's not excellent. But graft failure, actually 53 to 73 did not change. So graft healing is essential to improve shoulder function, even for revision H&UL. And we compare the immobilization 4 weeks, 6 weeks, because for primary H&UL, I immobilize the shoulder joint for 4 weeks after H&UL. That's why I studied the 4 weeks immobilization after H&UL. But the graft tear rate actually very high, 33.3%. I cannot accept this number. So since 2020, I changed to 6 weeks immobilization. Then graft tear rate decreased 12.5%. But still, it's not so low. So still we need to think about how to prevent graft tear for after revision SCR. SS score 4 weeks immobilization improved 21 to 75, but 75 is not good result. And 6 weeks is a little bit better, 33 to 83. And the active elevation increased from 58 to 130, and 6 weeks 83 to 143. So from this data, 6 weeks immobilization is recommended for revision SCR. I want to show case 1. It's active elevation 40 degrees before surgery. This is a really fast cases of the revision SCR. It's a massive root cuff tear. But at that time, it's almost 20 years ago, so I did not study the SCR, so I did the arthroscopic rotator cuff repair for this kind of the large tear. From grommelar joint, this is a torn tendon tissue. It's very tight, even after immobilization. It's a mobilization. Then from subacromial space, at that time I did the margin convergence first. Then at the repair the tendon to the great velocity. So we could do the complete repair for this patient, and from the grommelar joint, the repaired. But actually, margin convergence I stopped because of very high rate of retear, because the tendon tissue is very tight and very degenerated. Then this patient, 3 months after local repair, we could see some continuity, but a very thin tendon tissue. So Suga classification 3. But 6 months after local repair, we could see the retear after retear of the repaired tendon. So Suga type 5. And then we tried to do the 6 months the physical therapy still, but he couldn't elevate arm. So we did a supercuff reconstruction for this patient. And this is a suture here. And from grommelar joint view, you can see the acromion from grommelar joint. And the subacromial space, you can see the adhesion between the acromion and the torn tendon. And then it's very tight and very degenerated, the torn tendon edge. So we did SCR. Now this is the graft. It's a different technique than compared. It's because it's a very fast surgery of the SCR. But actually, graft is very good fixation, and the red part is teres minor. Then from the grommelar joint, you can see the graft here. Then finally, 6 months after SCR, he could elevate arm. Actually, this patient, 1 year before local repair and 1 year after local repair, 2 years he couldn't elevate arm, but now he can elevate arm after SCR. So now he's very, very happy. And now 10 years after SCR, graft looks a little bit thinner, but actually still intact. And he, no problem at all, and he is satisfied with this surgery. And the second case, the active elevation 90 degrees, but this is a very recent case. So I want to show the current technique. And he did the local repair in other hospital, and the other doctor did the local repair, but failed. Then he came to my clinic, and then we did the SCR. It's from posterior view, the grommelar joint. There you can see the sutures and subacromial space, many sutures there, but no tendon tissue on the humeral head. And first, we need to remove all of the sutures and cut and pull out. Then some of the suture we take out using the shaver. So afterwards, we start the SCR. This is like a large tear, and the tendon tissue is very tight. Then you can see the suture anchor here, but he used a biocomposite anchor, so we did not remove. Then we, as always, we do the acroplasty very well. Then now we have a joint. We release the labrum between the labrum and posterior superior capsule and infraspinatus and teres minor to expose the supraglenoid. Then remove the soft tissue on the supraglenoid. Then afterwards, I usually keep the biceps there. Then behind the biceps, you can see the coracoid base. So now here is the coracoid, and the coracoid base, we inserted the suture anchor or the anterior glenoid anchor. It's usually use a 4.5 or 4.75 millimeter screw suture anchor. And the posterior glenoid, posterior supraglenoid, the nebulizer portal, we insert the one more anchor. Even the massivity, so 2 glenoid suture anchor is enough. Then afterwards, the 2 suture anchor with tape is inserted to the medial footprint. Yeah. Again, the 2 suture anchor is enough for even the large tear. Then all of the suture attached to the graft outside the body. Then now I'm inserting the graft to the joint. Then graft is coming to the joint. This is graft. Then so most of the case, rotator cuff tendon tissue is there. So we need to pull up the rotator cuff tendon. Then under the tendon, we push the graft more medially. Then after we confirm the graft is reached to the glenoid, then not tying all of it for suture. Then after fix the glenoid side, lateral side is the suture bridge, actually speed bridge, using a knotless suture anchor. Then finally, the posterior side suture between the graft and the tendon tissue. We usually do the 2 side to the suture posterior side between the graft and tendon. But this patient, some good tissue on the infront, the supraspinatus tendon edge. So I made 2 more sutures. So 4 sides of suture I apply this patient. So now second suturing and third one using the suture lasso or AccuPath or GEA or Easy Pass, any suture passing device is available. And the medial side, it's a graft to the supraspinatus tendon tissue. Supra is very degenerated, but I not time for this patient. So 4 sides of suture. This is the final view. This is the graft and the tendon. So lateral side is the speed bridge here. Then 1 year after issue, he can elevate on 170 degree, and the graft is excellent. Actually, the very thick graft is there because now I recommend 6 to 8 millimeter graft, and I use the 6 to 8 millimeter thickness of graft. So the post-operative MRI shows very thick graft like this. Then finally, one more case. This MRI is a before local repair in other hospital. It's a massive tear and very degenerated, almost no tendon tissue. Then just a local repair in other hospital, the other surgeon said he did a complete local repair, but just after local repair, the MRI shows already torn, or I don't know, he may did the partial repair, but anyway, did not repair completely. Then after 7 months after surgery, they actually Marshall was the tendon tissue there, and problem of this patient is the tuberosity he did with local repair. So 7 months after local repair, no greater tuberosity. So to get a good outcome, after SCR, growth velocity is necessary. So that is the problem, but his elevation only 30 degrees, and he wanted to do the SCR, so we did SCR. Then 2 years after surgery, the no growth velocity here, but fortunately, graft is still intact. But after elevation, 150 degrees. 150 degrees is not bad, but actually, if this patient had a greater velocity before SCR, maybe he could elevate on 170 or 180. So anyway, tuberculoplasty during primary aortic repair makes worse outcome after revision SCR. So I don't recommend tuberculoplasty if you think you may do the SCR for the revision case. And next, I want to tell about how to prevent retear after repair. It's superficial reconstruction for reinforcement. It means the SCR plus scar repair, already published in the American Journal of Sports Medicine. And this is the result of this paper. It's only 34 patients, but actually red bar is a SCR plus scar repair. No rod curve retear after surgery. 0% retear. But on the other hand, rod curve repair alone, 4.4% retear. And then from 2013 to 2020, we have done 155 cases of this surgery, but still 0% retear. So I recommend this surgery for the degenerated but reparable, reducible rod curve tear. So take-home message here, SCR can make functional improvement and pain relief even for retear after rod curve repair. 6 weeks immobilization is recommended for revision SCR to prevent graft tear. Tuberculoplasty is the first rod curve repair makes worse outcome after revision SCR. And the revision SCR had higher graft tear rate and lower functional outcome than primary SCR because patients with retear after rod curve repair have already had cuff tear arthroplasty or poor bone quality or severe muscle atrophy in shoulder joint. So we should focus on how to prevent retear after rod curve repair. SCR for reinforcement completely prevents post-operative retear after rod curve repairs. Therefore, SCR for reinforcement is strongly recommended to prevent retear after rod curve repair and revision surgery. Thank you for attention.
Thank you, Teru. Yeah. We have a lot of questions from the audience. So
okay, now or later?
No, now. Yeah.
Oh, okay.
Because forget the Sang-Jin Shin.
Okay.
The first question is the strength after the SCR, which is higher. You got the higher strength elevation or external rotation after the SCR. That is.
Okay, yeah. I made some research, clinical research. Then we checked the shoulder strength after SCR. Then, yeah, roughly the abduction strength is recover almost average 80% to the contralateral side, and the external rotation also around 70 or 80%. Of the contralateral side. Internal rotation strength depends on subscapularis. So, but actually most of the patients have the reparable subscapularis. So if you can repair the subscapularis, internal rotation strength almost 100% recover. So yeah, it's not complete and not 100%. Some patients, maybe 20% or 30% of the SCR patient can return to the 100% of the abduction strength, but actually it's not many. So most of the patients, 80% or around there.
Okay, RHEE, could you introduce the question from the audience?
So if like the patient like a teres minor is also like highly fat defect and or no function, do you think the SCR is still work?
Yeah, actually, still we do. Actually, this question is the primary issue or revision issue, or doesn't matter? Both.
I think it doesn't matter. So it's like
Okay.
the posterior part totally.
Okay. Yeah. So anyway, I do the issue in the three tendon tear, supra-infra-teres minor, and but this patient, the recover actually elevation is recovered very well, but external rotation very weak. So actually, the before surgery, this patient has an external rotation lag sign, but after surgery, they can hold it the external rotation position, but still maybe external rotation angle is 20 degree or 30 degree only. So not 60, 70, they cannot reach.
Okay, another question from the audience is that when you do the revision SCR, where's the location for the repair and when? So the 6 months later or 2 months later or 1 year later?
Yeah, actually, okay. In my clinic, as I show the SCR plus cuff repair, after I studied this surgery, there's almost no repair patients. So my patient or the revision case is actually first surgery is the other hospital. So it's so sometimes the 6 months of surgery they come to my clinic, but sometimes the
no. He asked you
okay.
When repair after the revision SCR, when you do the revision SCR and the location of the repair.
Okay.
Talking about the whole cases of revision.
Okay, yeah. Actually, graft tear is first MRI I take the 3 months after surgery. Then most of the case 3 months after surgery we could see the graft tear. So maybe just after surgery, maybe the one month immobilization we do. So maybe during the immobilization period, maybe no tear, but just after study the range of motion exercise, they have the graft tear, I think. So maybe 2 months, 3 months, mostly.
Okay. So the location, the glenoid side or humeral side?
Yeah, so I checked this time, then mostly the posterior side. The posterior side, between the graft, first we could see the repair between the graft and the tendon tissue. The posterior side is a suture press. Then graft is moved to the anterior, shifted anteriorly. Then maybe 6 months, 1 year later, then graft is getting thinner and thinner, and maybe the graft is getting maybe the graft, the defect is getting bigger and bigger. So most of the cases is posterior side.
Okay. So another question is, which is your proximal thigh fascia lata or mid thigh fascia lata to reduce retear rate? Proximal.
Yeah, proximal, because the revision issue mostly the big tear. So we need to harvest the big tear graft. So like 4 centimeter, 5 centimeter by maybe 12 centimeter, so very big graft. So only the proximal side we can harvest this much of the graft.
Okay, the Emmanuel asked, do you prefer fascia lata autograft or derma graft for revision cases? I think he missed your slide. You already choose fascia lata.
Yeah, so derma graft I don't recommend. That already the almost 10-year experience in the United States. Then that's not good results, even the primary cases. So maybe the revision case, it doesn't work, I think. So I don't recommend.
Yeah, but don't surprise. I've done I've done the 6 cases as a CR. So 20 cases of fascia lata. Yeah, 40 cases of dermal allograft.
Oh, okay.
But it's almost same. But you already mentioned about 15% elongation when we choose the dermal allograft.
Yeah.
Anyway, the last question is, how do you exclude the infection in the failed repair?
Oh, yeah. So it's very important question, actually. Recently, I don't have the infection at all. So maybe last 5 or 6 years, we have not seen the infection. But before that, I have some infection. Why I could prevent the infection, because it's a chlorhexidine. Before surgery, I use the chlorhexidine, and also during the surgery, and all suture anchor and sutures before inserting to the body, I always put the chlorhexidine. That's why maybe I can prevent the infection after surgery.
So what is your important lab before the surgery to check out rule out the infection before the SCR?
Before surgery, again?
Laboratory study. What is the most important laboratory study to rule out the infection?
Yeah, so that is good question too. Mostly the acne. So acne does not increase their white blood cell. So most of the case, the white blood cell does not increase, but CRP is usually increased to 5 or 6 or 7, not too much, not more than 10, mostly 5 or 6 around that. And also MRI is it works very well. You can see the infection very well. And also sometimes if you have the good MRI, maybe you can see where the focus on the infection. So sometimes the suture anchor, sometimes that suture. Then I take out the suture.
Okay.
Yeah, but
so what do you think about the joint fluid?
Joint fluid?
Yes. Why didn't check the joint fluid?
Yeah. So sometimes we take out the joint fluid, then culture, then maybe we can see the C acne or P acne. And also MRI, we can see the joint fluid. Then usually after ACL, not so many joint fluid. So if you see many joint fluid, it may be the infection.
Okay.
In my experience, if the sugar in the joint fluid is really low, like close to 0, much lower than the blood sugar at the same times, it means in the joint there's something like so to take the sugar away. So usually it's just like the infection. So this is in my way, this is the quickest way to check if any bacteria in the joint.
Yeah,
okay,
I agree.
Agree or not?
I want to ask you, this is the last question for you. What is your current effort to make a 0 retear rate after the SCR?
Yeah, so still 3 to 5% graft tear rate. So maybe we have to think about how to make much stronger graft, but it's not easy.
Yeah. Thank you, Teru. Now, hey, Jui, you are moderator, so you can manage the speakers. Okay, from now.
Okay. So next speaker is Sang-Jin Shin. It's our friends. His topic about revision of rotator cuff surgery. Come on, Shin.
Okay. Okay. Now I'm talking about revision rotator cuff repair, except the SCL. SCL already Teru told about that. So how to handle failed rotator cuff repair? Important thing is don't make failed rotator cuff repair. How? Appropriate procedures from pre-op to post-op. Pre-operatively, we need to know our own repairability. So that's why we need to choose appropriate treatment option. Intraoperatively, we need to choose appropriate technique between repair or augmentation. Post-operatively, definitely appropriate rehabilitation is very important. If repair is inevitable, make an asymptomatic rotator cuff failure. For assessment of tear repairability preoperatively, we need to use clinical findings, plain radiographs, and MRI. It will be very helpful if everybody has their own repairability index. So I analyzed my patient who had a rotator cuff tear more than 2 cm. So I analyzed this kind of imaging factors and functions, and then run statistics. I obtained the cutoff values and odds ratio. My repairability index is that highest odds ratio is muscle atrophy of supraspinatus. Then next is a fatty infiltration of infraspinatus, grade more than 2, and then tear length, ML size more than 26 millimeters, remnant tendon less than 50 millimeters. Using that score, I analyze and then I assess my repairability preoperatively. Intraoperatively, I need to do some augmentation. For ortho tendon, I use biceps augmentation, usually in anterior L-shaped rotator cuff tear. You see, there are 3 ways to use biceps as augmentation materials. I like to use the anterior cable reconstruction after cutting the distal part of biceps tendon. So the principle is I put biceps using 2 tenodesis point. So medial tenodesis, I put anchors where the infraspinatus can come anteriorly as possible. After tenodesis, and I put my biceps beside the infra. Using those sutures, I tied it together, supra and then infra on the biceps. And then lateral tenodesis, also I put anchors where the infraspinatus can come anteriorly. So I can repair the infra and the supra without undue tension, and that biceps tendon as an autograft and then roll as a anterior cables. So my repair rate is about 18%. Once supraspinatus can come to the medial part of footprint after medialization without less tension, I do patch augmentation like this. So preoperatively, that much tear, then I put patch augmentation. The post-op 6 months MRI shows that patch was intact, and then below that, there is a tendon-like soft tissue is regenerate, we can see. Definitely SCL I do to reduce the retear. Not like Teru, I use acellular dermal matrix. The thickness is more than 4 to 5 millimeters. And then I made extra 15 millimeters medial side of ADM. So I can those parts push below the remnant supraspinous tendon. And then I use the customized lateral portal divider not to tangle the sutures, and then to reduce the number of sutures into the subarachnoid space, I use dual pulley technique on medial side. Then I suture with remnant rotator cuff tendon. That's my tip to reduce the retear rate after SCL. That's my technique. And then briefly, that's my lateral portal divider, and then preparation outside the shoulder, and then put it back. Lateral suture bridge technique, and then medial, I sutured my graft with a remnant supraspinous tendon, and then post side-to-side repair. 6 months after operation. Anyway, all this effort, preoperatively, intraoperatively, still retear rates so high, ranges from 10% to 57%. But patients retear. Sometimes they don't have symptoms, and sometimes they have. There are a lot of factors as introduced related with retears. So age, pre-op tail size, fatty infiltration. And also I want to know my retear factors, which causes retear. So my analysis is that initial tear size and then fatty degeneration more than grade 3 is closely related with my retear factors. But everybody knows that the retear does mean poor functional prognosis. Pain relief and function improves despite of retear. So retear alone did not affect patient satisfaction. But sometimes we meet the retear patient with highly symptomatic patients. So that was my question. I was curious about what causes symptomatic failed rotator cuff repair. So in my retear patients, I analyzed and then I divided into 2 groups. Symptomatic failed rotator cuff repair who needs revision surgeries compared to the failed rotator cuff repair with or without symptoms. So most powerful predictor of symptomatic failed rotator cuff repair is the relative tear size change of AP diameters. Second is ML diameters. So see this. So preoperative tear size like that. After repair it, I got retear. But if you compare the AP size, pre-op and post-op MRI, the post-op MRI is larger than preoperative AP tear size. This patient has a high chance to have symptoms. But if you compare this one, the large tear, when I repair it, although I have a retear, but when I compare the post-op AP tear size to the pre-op AP tear size, retear size was smaller. So this patient has a less chance to have symptoms. So independent predictor of symptomatic failed rotator cuff repair is relative change in AP tear size. So other thing is the serum cholesterol and then fatty degeneration infraspinatus was closely related with symptomatic retear. So every time I do repair, I always think about if retear occurs, how can I avoid the symptoms? So try to reduce AP direction tear size. So in this kind of large tear, using one pair of sutures, like that, you see that I sutured in horizontal matrix pattern, then that sutures independently blocks its way to progression. So other sutures, I use those sutures for suture bridge technique, but this, I call it stopping sutures. Whenever the retear occurs from anterior, that horizontal matrix will block its progress to the posterior side to try to reduce the AP tear size. So improved clinical outcomes after retear, we know why. So I think the subarachnoid decompression and debridement will definitely have a role to reduce the symptoms. Definitely retear is smaller than original tear size. That causes restore the false couple that leads to less symptom after retear. And then another paper said that the active patient has more poor function and structural failure with the retear after retear. And then another question is, when do we do revision surgeries? So I found that revision surgeries, who needs revision surgery within 1 year after primary repair, has a significantly worse clinical outcomes after primary surgery. And then tendon to bone area healing failure, and then full thickness tear of subscapularis. This patient has a chance to have early revision surgeries, but muscle weakness is the main cause of late revision surgeries. Still, revision surgery is challenging. The challenging because concomitant lesions which is not found detected on MRI, and then adhesion of cuff tissues with acromion or deltoid, and then consider previous anchor fixation site that just where we need to put. So this kind of technical problems we can meet in the revision surgeries. So unpredictable tendon quality. If you see this one before debridement, it looks so small retear size, but after debridement, that small retear size becomes a large, and we need some kind of augmentation for that. Anyway, still, once you decide the revision surgery, you need to set your revision timing based on patient symptom, and then revision technique, patient age, and then retear size. Definitely, we can use these 6 techniques. You can repair completely again, and then partial repair and autograft, partial repair or allograft, tendon transfer, and then SCL, and then finally reverse shoulder arthroplasty. So this kind of revision repair, the post-op AP tear size is not that big, so we can repair directly using other suture techniques, suture repair techniques. Once I debride this retone tendon, it looks like U-shaped, so I used modified double row fixation technique using 2 suture anchors. I gather that the tendons together side by side. That's kind of side to side repair using suture as suture anchors. So in that case, we can obtain the good result and then good tendon continuity with a higher satisfaction from the patient. So clinical outcomes, definitely after rotator cuff re-repair, the significant improvement we can obtain, but not as good as primary repair. So comparable short-term outcomes, but still higher repair rate. So factors related to repair after revision surgery is preoperative, supraspinous atrophy, and fatty infiltration are the most contributing factors re-repair after primary rotator cuff repair. So we can revision using SCL, but it will be the same technique, the Teru showed, and I will skip that. So we can use patch augmentation as a revision technique. So there's a remnant suture anchors. I cut the biceps. After debridement, I assess the tendon of the retracted supraspinatus tendon. I removed all sutures. Once retracted supraspinatus can come to the medialized footprint, I decide to use patch augmentation. So after put suture anchors in the medial part, and then I pass the sutures to use a suture bridge technique. So after touch down those tendons to the medial side of footprint, using those sutures, I passed the patch augmentation. I used the dimension is 2.3 millimeters, 3 centimeters, and then thickness is 2 to 3 millimeters ADM I use. So I can get that patch augmentation for repair revision technique. So repair doesn't occur, and then post-op MRI shows a good collaboration with the patch and then repaired tendons. So, but still revision with patch augmentation has a higher failure rate 30 to 34% has been reported. So revision using autograft. So as I mentioned earlier, I use biceps tendon as an autograft. In that kind of revision surgeries, it's kind of L-shape. I can use it by biceps tendon after cut the distal part. But in that case, the return tendon is always weaker than the primary tendons. So I try to put biceps or patch as an augmentation material. So medial tenodesis, and then using those sutures, I passed supra and then infra, try to put the supra and infra together on the biceps to reduce the tension. And then I try to put my biceps just beside the infraspinatus. And then I try to take my infra to the anterior as possible. Once that technique has failed, but still my repair patients still have a smaller AP diameter compared to the preoperative tail size, then I can have a higher chance to have a asymptomatic repair. So always try to reduce AP tail size. This is post-op MRI. And then revision using RSA, definitely elderly patient with a massive tear. I don't have any hesitation to have a arthroplasty as a revision technique. So clinical outcomes reverse, it's a comparable, but the shoulder arthroscopy performed within 2 years before shoulder arthroplasty is associated with a higher infection rate. You need to remember this. So take-home message. So choose appropriate treatment method after assessment of preoperative repairability, and then try to reduce AP dimension to avoid symptomatic rotator cuff failure. Revision timing is determined based on patient symptom. Applied various revision surgical methods based on patient age and then rotator cuff retail size. Thank you for your attention.
So, Sang-Jin Shin.
Yes.
So, see, there's any question from audience?
The first is, hey, Sang-Jin Shin, you know, you took us 3 minutes more, three more minutes for your presentation.
Sorry about that. I tried to reduce discussion time. Sorry about that.
So we had there's some question. When you have a retracted rotator cuff tear, and then you got the very successful repair, and then you usually check the muscle volume of the supraspinatus through the post-op MRI or not?
Yeah, my repairability index that shows the atrophy of supraspinatus tendon is very important, because as you mentioned that I think that the volume of supraspinatus represent the elasticity of the tone tendon. That's very important. I always check the atrophy status of supraspinatus to choose the appropriate treatment method.
So I mean the post-op MRI. You check the volume of the supraspinatus. I mean the muscle.
Muscle.
Yeah, that is his question. Stored proper.
After repair.
Yeah.
After repair, once it healed. No, that I cannot see his question, but
yeah, you don't care. The most volume.
So, yeah. After repair revision, I don't check because already game is over. But before operation, I check the muscle status.
Okay. Yeah. You had excellent presentation, and the tear rate is the symptom is related with the AP diameter. after the repair. But my question is, you checked only AP or medial lateral direction of the repair, but that is really related with the symptom or not? Because if patient has the synovitis, I think the symptom should be related with the synovitis, but you didn't check the synovitis.
So that conclusion is I analyze everything, the MRI or patient demographic and everything. Then I run the statistics. Those two things are most contributing factors for symptomatic rotator cuff re-tear. But synovitis, definitely that's very important, but I don't have any measurement assessment to analyze the synovitis before operation, something like that. So that's why I don't take the synovitis status in that analyze. But yeah, everybody knows that synovitis definitely causes symptoms after re-tear.
And do you use steroid injections like just after repair for the synovitis patient?
Yes. I wrote paper about that, 2016 AJSM. So some patient who complained of severe pain more than VAS score 5 and 7 while I'm doing immobilization. So I wonder why. What causes that severe pain? That means that, as you said, that's a bursitis and synovitis in the subacral space. So in that early area, 4 months, between 4 weeks and 6 weeks, I injected steroid in the subacral space. Some surgeons, they advocated to inject 3 months after repair. But I think that 3 months already stiffness has occurred. The patient already has a stiffness and then pain. So I try to reduce that kind of stiffness and pain before it occurs. So for me, from my experience, there is no infection related to steroid, no re-tear rate increase related to steroid. So if somebody has a pain after 1 month while we are doing immobilization of their shoulders, I recommend the steroid injection in subacral space because of bursitis.
So I mean, just after operation, like during the operation, you do the injection of steroid?
No.
No, never?
No, never. Why?
It's because like synovitis is serious, and the patient like after repair, the patient still have serious pain because synovitis. But if you do the injection of steroid, and the pain decrease. Better for feeding?
Yeah, so I agree, but usually the pain right after the operation is because of procedures, I believe. In that case, my anesthesiologist, we do interscalene block or SSMB just right after operation. Now, while I'm doing the operation, I try to remove all the bursitis I found from anterior to posterior lateral medial, then can reduce the postural pain. But what I mean, the steroid injection is about 1 month and 6 weeks after operation.
5 minutes left, but one more catch-up from Mohammed Joha or Homa. What are your results with biceps augmentation?
Biceps augmentation, I don't have a biceps augmentation after revision surgery, but my primary surgery of biceps augmentation is 18.7% re-tear rate. And then most surgeons, they worried about the Popeye sign after that kind of distal cut. My report is 12%, but most of them are elderly patients, especially female patients. They're not complaining of that kind of cosmetic problems. So my result are 18%. My previous biceps augmentation moved biceps into AP direction was repair rate was 32%. So I reduced that high rate repair rate into the half. So now I'm doing that biceps augmentation as anterior cable reconstruction, especially in anterior supra-retracted relative preserved infra kind of tear pattern. That means the anterior L-shaped tear pattern.
So you mentioned about the anterior cable reconstruction. It's a good idea for using the biceps, like as a biceps rerouting.
Yes.
Then
yes.
what is the distance from the original bicep groove when you make a trough for the biceps rerouting? It's 1 cm or 5 millimeter, or you make a trough oblique line or almost vertical line?
Usually, I don't make trough because I already decorticated, and then I think that tenodesis point location is depends on the infraspinatus status. Where the infraspinatus can come anterior as possible, then I put the suture anchors for tenodesis. It usually around 1 cm after original groove, sometimes 1.5 cm posterior to the original groove. That's why I don't like to move that biceps that much without cutting down the distal part.
Okay. From the Stuart proper, he had a lot of questions. And when you allow this strengthening exercise after the revision tendon rotator cuff repair, strengthening exercise.
So revision and then the primary repair are always the same, except SCL, because SCL we put graft on the surgical field. So I mobilized 6 weeks. All repair, I started stretching exercise from 1 month after operation. Once their patients restore the forward flexion, I teach them light strengthening exercise with band from 3 months after operation. But real strengthening exercise, I recommend them to do 6 months after operation once we confirm the repaired tendon status, healed or repaired.
So, Jui, you have a same rehab program?
Yes, usually for revision case, we also stabilize for 3 months, just for passive movement.
Okay. It's almost one. So the last question, you talk about the rehabilitation, reparability before the surgery.
Yes.
So MRI is the most important. What kind of physical examination, or can you get some reparability through the plain X-ray?
No, some prefer the stress X-ray, but I don't believe that one. I only believe the MRI status.
You don't believe Jeon?
I don't believe him.
Because
no, I don't think that the stress exercise can explain about the repairability. But as I showed many techniques of revision surgery, so you can have your own strategy. Okay, allograft for this, autograft for this, and then direct repair. Then you have many weapons to fight with the revision surgeries.
So you usually check the subscapularis as intact.
Yes, subscap and then muscular atrophy and then teresma definitely. Yeah.
Okay. Jui, could you move? Now time to move.
Okay, so if so next is Gupta. So talking about the revision surgery for total shoulder arthroplasty.
Thanks, Chui. Can everyone hear me?
Yeah.
Perfect. And I'll share a different screen. Okay, can you see my slides?
Yeah. Good. Very nice.
Perfect. So I'd like to thank Christine Italia, who's helped me prepare this talk. And I'll be talking about single stage revision arthroplasty because that's the topic which is given to me. And I'll try and do a decent job after such stellar, talks which have been given before me. These are my disclosures. This is the team or part of the team I work with. And I have disclosures for Acuna, which is my company. So revision shoulder arthroplasty is a very complex problem. And what I believe is that if you have a very complex problem, you break the big problem into smaller problems. And I like to fix up every small problem, and then the big problem gets solved. So what I've been doing for quite a few years now is I've converted all my revision arthroplasty into a single stage procedure. And I've been doing this since 2018 now, so it's 5 years, roughly 4.5 years. And I've converted it into a single stage, two-step process. The patient needs to be medically stable to tolerate a 6 to 7 hour operation. They need to be a type A and B host, and there should not be any gram-negative organisms in the shoulder. So what I do is in the step 1, I debride and explant the implant. I dissect the plexus, I tag the tendons, and then we cover the joint with vancomycin, put vancomycin in the joint, close the skin, we go have lunch, and then we come back, and then we re-prep and re-drape, and there's a new set of nurses, new instruments, and we go back in and reconstruct the shoulder. And for this, it's really important to have preoperative planning for your reconstruction, which is done. And I'll talk a bit about that. So in step number 1, I'm going to debride everything meticulously. I'm going to explant all the implants, tag all the tendons and the nerves, and dissect the plexus. Because if the plexus is caught, or especially the axillary nerve is caught, it's a big risk and a big problem for post-operative pain. So it's a team approach. I always used my same team for this operation. It's a very extensile approach. So delta pectoral approach is used. Everything's debrided. Everything's explanted very carefully. Then I save the attachments of latissimus dorsi, teres major, and pec major, because often you need to do tendon transfers because of deficiency of the cuff. I lavage the joint with 12 to 14 liters. Then I do a second loop debridement, and then I put 2 grams of vancomycin in the shoulder, and then I close the wound. And then I said we re-prep and drape and come back with new instruments, and then have a second loop debridement again. And then I reconstruct the glenoid. And then I'll talk about the joint line philosophy, which I have here, which I want to reconstruct the glenoid. And I want to reconstruct the humerus, either with metal or an allograft prosthetic complex. And then most important bit is to reattach all the tendons to ensure that there's stability. And then at the end, the plexus is checked. I give all my patients IV cefazolin or vancomycin plus lincomycin for 2 weeks. And then I check about the cultures. If the cultures are negative at 2 weeks, then I give them oral clindamycin for 6 weeks and rifampicin for 6 weeks. If the cultures are positive, they get IV lincomycin for 6 weeks with oral clindamycin, and usually IV cefazolin and lincomycin with rifampicin for 3 months. So now I'll talk about a concept about what do we do. So one of the very important concepts I've learned is that it's very important to create the normal joint line. And this is the work I did when I did my master's many, many years ago, is looked at where the normal joint line is. And it's roughly 8 to 10 millimeters. It's 8 millimeters in a female and 10 millimeters in a male from the base of the coracoid. And it's like a soccer field. So this is where the zero line is. when we have bone loss or when we do a reverse shoulder replacement, we are always lateralizing the joint line. So it doesn't matter whether you use a Grammont design or you use an onlay design, your joint line is always lateralized. When we have revisions, the joint line is always medialized. So it's really important to understand that the first thing which we have to do is get this joint line back to normal. And this can be done either with metal or this can be done with bone, and that's the dealer's choice, because then that gives you a benchmark as to where you need to put your humerus and your soft tissues to be able to give stability. So this is a case, of a reverse shoulder replacement, and this is a complication which occurred within 3 years. It's not one of my cases, but this patient has had an acromial stress fracture. They've had notching. They've had an oversized stem which has been put in, so there's significant stress shielding, and everything's gone wrong in this case. So how do we tackle things like this? And this brings about the concept of humeral length, which is really important to restore as well, not only the glenoid length. And in cases like this, I've been using preoperative planning for revisions now for over 5 years. And this really helps you figure out where the joint line needs to be. When you have tuberosity escape at the back, how can we get the tuberosity back and restore function? So this is a patient who had a failed RSA, 18 months post-op. It was done by a very good surgeon. Unfortunately, it failed and it was not infected. And this is a case I did when I came back from fellowship in 2016. And, this is the kind of bone defects you often deal with when the grafts fail quite miserably. The glenoid is pencil thin. You have a scapular spine, which is 4 centimeters medial. And at that point of time, I did not have preoperative planning for this case. And I just, did it. But then later on, when we develop preoperative planning and when you can segment with metal already in there, this is the way the graft looks like. And now if I would plan this case now, this is what this bone defect would look like if I went into this case with preoperative planning with Metal Institute. So this is what I did. I bone grafted this case with femoral allograft, and I was able to restore the joint line back to normal. And this is their 2-year post-operative CT, shows that the graft's completely incorporated. So it's really important to restore the joint line and restore so that the function can get restored. And this shows how the joint line's restored. And this is the function you get for a patient like this, who had quite an unsalvageable reverse shoulder replacement, who was doing really well. So now, since the last 2 years, we've taken this further and we are using, we can give quite advanced measurements of bone loss and version and inclination in the keeping of metal. And this has been developed into a service which, surgeons across the world can use for complex arthroplasty where the implants are already there. And, this is coupled with the use of mixed reality now and holograms, which allow us as surgeons to plan multiple different implants, multiple different plans for your revision. You can have a plan A, plan B, plan C, and have holograms for all of these plans, which you can't really do with just simple PSI guides. And the future here is going to be navigation of this with the guided holograms, which will be very soon. So, this is how the holograms really help us during the surgery, and it really helps you see beyond the wall because you can see the whole scapula. You can manipulate the whole scapula, and it really helps us in revision arthroplasty. So now it's not just about bone. We all know arthroplasty is a soft tissue operation, and it's really important to restore function. And this, is one of the dissections I did when I visited Chanakarn in his lab. He's got an amazing cadaveric lab and a facility there in Thailand. And, this is the latissimus dorsi, and you can see how close the axillary nerve is to the latissimus dorsi. And all of this soft tissue needs to be maintained. And if we don't maintain the soft tissue, then, we get problems later on. And it's very important to see that the latissimus dorsi is running in one direction and the teres major is running in a different direction, because often in cases like this, where you have symptomatic instability of a reverse, in a case like this, all I have done here is then gone in and done a latissimus dorsi transfer to this patient, and that stabilized the joint completely, and I upsized the polyethylene. Another difficult situation where you have a periprosthetic fracture and notching and a loose glenoid and a loose humerus, the arms in a sling. What do you do? In a case like this, I've restored this with, a humeral allograft and then done a whole heap of tendon transfers here to give stability. And this is the kind of function you can get in this patient in 6 months who could not get hand to mouth for over 2 years. So I wanted to talk a few things about hemiarthroplasty and fractures because that's a very common revision which is done in Asia. So this is a chap who's had a hemiarthroplasty which failed, and he had this for 25 years. And no hemiarthroplasty is without problems in the long run. So in my career, I've hardly ever done any hemiarthroplasties because I've seen that the scores of the patients postoperatively are very poor. So if we embark on a case here without planning, this is the CT scan you have. And then what this gets converted into is a very complex plan which shows you how significant your bone loss is. And then when you can look at the other side and compare this with the other side of the patient or a statistical shape model, you can understand how much of the joint line needs to be recreated, what kind of version and bone loss we've got, which allows you in a very reliable manner then to see what the bone loss is intraoperatively and how the holograms really help guide this operation. And then this is that patient postoperatively. And these are his functional scores on the platform. So we have a whole platform which marries function of the patient with planning. And you can see that, the range of motion and strength and function constantly keep improving. Infections. I've been doing all infections as a single stage. And, this is a patient who unfortunately had a sinus fistula. He had good movement, but he had an open sinus fistula. And I did a single stage revision on him. And, this is his function 6 months postoperatively with a single stage revision with implant retention. This is another patient who, has quite a bad infection who's come to me. And I removed everything here. And reconstructed everything in a same setting in a 2-step single stage procedure, and they've done well. Proximal humerus fractures are a big challenge, and I find this is one of the hardest arthroplasties to perform. And most surgeons take on reverse shoulder replacement after a failed ORIF, but I will caution you that this is one of the hardest joint replacements to perform. So if you look at an X-ray, this might not look that bad. This person has an active elevation of 10 degrees only. When we convert this into a 3-dimensional plan or a CT scan, the story changes quite a lot. And then you can start analyzing the malrotation of the humeral head, the penetration of the screws, the tight joint capsule, and what needs to be done to the glenoid. Often there's a windscreen vipering effect. But these can be done well. And, this is the end result with the reverse in these patients. And you can see for someone who had very poor function to start with, the range of motion constantly keeps improving. And the fractures just keep getting more and more complicated. This is a 73-year-old patient. I've done this a few months ago. Had a long history of multiple operations, very poor function. This is their preoperative plan for a complex situation like this. And then, with the planning software, with revisions, you're really able to plan, take the metal out, analyze how you're going to position the graft, and if you can get a stem in a malunited humerus like this, what kind of stem do you need, what kind of implants you need, etc., etc. And then this is what I did for this patient. I revised it all in a single stage procedure. Again, we were able to get a normal stem in despite the malunion. And this is her function. She's only 2 months post-op after a single stage revision for someone who had an active elevation of only 20 degrees preoperatively. So she had very poor function for almost 10 years. And you can get really good, functional outcome of someone who's just only 8 weeks after surgery. This is a case I've done this week. Another, constant score of 36, functionally SES score of 13, very poor function, failed ORIF. You can see there is a greater tuberosity escape. And this is the biggest problem after a failed ORIF. When you have a GT escape, is to get this back to get external rotation. You can see this patient has no ER. When we plan this case, the whole GT is malunited. The axillary nerve is stuck between that fracture and that bone. And I know that this is going to be a really complex case. And I really like to thank the partnership with Zimmer Biomet here, where we've, been able to use our preoperative planning at Acuna with the CADs of Zimmer Biomet here to enable me to do these complex cases. And we've been able to plan this case with multiple different stem options to see what would work, a short stem, a long stem, a stubby stem, and what if I have to do an osteotomy to get the GT back on, and what kind of screws I need to remove. So this, if you can see here, a couple of the screws have been put under the plate. So I would not have known this if I did not do the preoperative planning, and then I planned to cut the plate off so that I could get my stem in position. The glenoid was relatively easy. So this is the osteotomy, which is a very important point of the operation, is that you have to mobilize the GT completely because this needs to be reattached again. The axillary nerve was stuck here. I had to chisel it out with an osteotome, so it took quite a few hours, but we were able to achieve a good result. And it was exactly like what we had preoperative planned. So I'll stop here. We've got really good results of these, and I won't talk about this. We see the forward elevation is significantly improved. External rotation, more importantly, we've got 40 degrees of external rotation on our patients. The hospital stay is reduced. The patient satisfaction is over 86%. And most importantly, there's a significant reduction in cost for people as well. So even in complex defects like this, single stage revisions can give us really good results. And I would recommend people to, embark on this journey, especially those who are used to doing arthroplasty or want to embark on revision arthroplasty. Thank you.
Thank you. We have 20 minutes discussion to Jui. Hey, hello, Jui, you are moderator.
So I just see is there any question from the audience. So wonderful presentations. So I just see even for the infected cases, and you do the one-step revisions. How many cases you have done for this kind of infection cases?
So, Chui, I just assume every revision is infected. So I do not do cultures preoperatively. I don't do aspirations. I don't do anything else. I assume that every revision I'm doing is infected. And in some cases, I find a bug, and the other cases, I don't find a bug. So far, I think I've done around maybe 50 or more single stage revisions now in total. And how many of them are infected? Maybe probably half of them I cultured something. I've done a lot of frank infections like the ones I showed you, but I treat them all in the same way, whether they're infected or not. I just treat everything as infected.
There's one question from the audience. Why is RE? Why orally pumping? Any special reason for using this anti-TB drug?
Yeah, I think so. One of my senior infectious disease physicians recommended this to me very early on when I was embarking on this journey. And oral rifampicin works very well against biofilm. So it's a very potent synergistic antibiotic which works against Staphylococcus and Propionibacterium biofilm infections. So he used to use it a lot for chronic osteomyelitis and in infections where metal isn't present. So because I'm re-implanting with metal implants and sometimes I'm doing implant retention, so I like to use rifampicin, and I think it makes a huge difference to cure the infections.
So as I know, the repumping can reduce the effusion. So have we ever experienced the control the effusion?
No, I haven't experienced that, Professor RHEE. I know that it can cause a bit of eosinophilia, And you have to monitor the eosinophils and the mast cells with rifampicin. But apart from that, I haven't had any other problem.
You talk about retention. So what is your indication of the prostatic retention?
That's a good question. So in almost every case, I would like to pull the humeral components out, because you can do a humeral osteotomy and pull the humeral components out, and then we can, circulage and salvage the humerus. But the problem comes with the glenoid base plate, especially in a reverse. And if the peg is completely incorporated with the glenoid base plate, then I leave the base plate in. So I pull out, I go in, I take the screws out, I take the glenosphere out. I use the curved saw, which we use for the lattice, all around the base plate, make a hole behind the base plate, and then I try and extract that. But if the base plate is completely fixed and the base plate is correctly positioned, if the base plate is malpositioned, if it's too high, then the base plate has to come out, because if the implant's not put in properly, you have to remove it. But if the base plate is well positioned, then I was taught this by Luc Favre and Ludwig Seebauer, actually, that means that the infection hasn't gone past the back of the base plate and the peg is well incorporated. In those cases, I leave the base plate, because taking that base plate out will damage too much of the glenoid bone stock. So I leave those base plates in, and then I will just go back in and just put new screws in, new glenosphere, and do the revision. And so far, I have good results with implant retention.
So I actually ask you, TAIR.
Yes.
Drainage, antibiotics, and irrigation and retention. So what is the time limitation? I mean, the symptom duration after the primary prosthesis. And then if we suspect the infection, what is your time to get the retention?
In my career so far, I've had 3 arthroplasties which have been infected, which are my arthroplasties, unfortunately. In all of these 3 arthroplasties, I was able to do the DARE procedure in 2 cases, and in 1 case, I had to pull everything out and revise everything else again. So I don't have a timeline to say whether 6 weeks or 3 months or 4 months is the accurate timeline for this. I go in there, I will pull the glenosphere out, the base plate out, the glenosphere out, the screws out, the polyethylene liner out. And then I scrape all around the top of the humerus, all around the liner, the metaphysis of the humerus. And then I'll check if the bone beyond the metaphysis is looking really pussy, or it looks like it's got osteomyelitis. If the bone below the top of the epiphysis of the humerus looks bad, then I pull the stem out. But if the bone below the epiphysis doesn't look bad, then I retain the humeral stem. And in regards to the base plate, I've just told you what I do with the base plate.
Okay. Gee, we have the question.
Yes. So for the revisions, usually the glenoid become really short. So do you have any, the length limit that's not enough to stabilize the base of the implant?
No, so I don't have any length limit. So we published on the 50% rule in our paper with Ludwig Seebauer in 2018, or 2016 or 17, I can't even remember when it was quite a few years ago, where we showed that if you can get a peg in the native scapula, at least a centimeter of the peg, you can get 2 locked screws in the native scapula, and 50% coverage of the bone graft and the base plate on the native scapula. If you have all 3 conditions, it's the 50% rule. And if you abide by the 50% rule, the base plate will be stable. So in my career so far, there's only 2 cases I can remember where I could not implant a glenoid in one go. And in those cases, I bone grafted the glenoid, and then I do not put a spacer in, because if you put a spacer in, it destroys your graft. I just leave them with the humerus floating free. and then I come back at 3 months, not at 6 weeks, not at 8 weeks, because it's not long enough. I come back at 3 months and then put the glenoid back in. But I've only had to do that 2 times in my career. I've never used a metal custom implant ever.
Okay. There's a question, how long do you keep the patients in hospital? This is a question from the steward proper.
2 weeks. I like to keep the patients in hospital for 14 days for 2 reasons. One is they've had a very big surgery and the arm usually swells up a lot, and I want to make sure they have edema management. Number 2, before I discharge the patients, I want to make sure the wound is completely healed and there's no oozing and no discharge for the wound. And secondly, I want to ensure that my cultures at 12 days, do not grow any P. acnes or propionibacterium or Cutinibacterium. So, because then that affects my antibiotics. So I tell all the patients preoperatively they were going to stay in hospital for 2 weeks. Usually they're in ICU or HDU for a day or two, in HDU for a day or two. And by then the wound is healed. I know what antibiotics I have to put them in. I know if it's infected or not infected, so I can make all of those decisions.
Yeah, so how much pay the patients for the 2 weeks hospitalization totally in Australia?
Well, most of them are privately insured, so it's covered by the fund. So it doesn't matter whether you stay for 1 day or you stay for 1 month, it's all covered by the insurance in Australia. But on an average in Australia, the cost per night to stay in hospital varies between $600 to $1,000, roughly.
Okay. I have the question, if we have a subcritical glenoid defect, which means the 10-degree retroversion or 15-degree retroversion, which is proper, the metal augmentation or the graft?
So that's a very good question, Prof. Rehee. So the way I look at this is I look at the age of the patient. So if the patient is a 50 or a 60 or a 70-year-old patient who I think is going to live 20 years and will need a revision, then I will always bone graft them. If there is a patient who is in their late 80s or in their 80s or is very osteoporotic, and I know that they're not going to live past 15 years, then in those patients, I use a metal augment. One of I've had 3 base plate failures now with the peg design in my career. Actually, 4th one just came in. And all these 4 patients who had aseptic loosening were on Prolia, which is one of the anti-osteoporotic medications, which they get every 6 months, the injection. So I have a big concern with patients being on Prolia, and I stopped their Prolia injection for 6 months before surgery. Because I'm really worried about aseptic loosening of base plates on them. And if a base plate is failing with a peg design, then a central screw base plate has no chance, because if you don't get ingrowth at the back of the central screw kind of base plate, then the screws are going to fracture and break, like the case I showed, which was the comprehensive, which had failed at 18 months. So that's my algorithm for bone graft versus metal augments.
Okay, one more question from the audience. In the case of humeral osteotomy in reverse, do you delay the shoulder movement after the operation?
No. So I functionally believe in this, that after arthroplasty, if it's not stable when you're closing up, the patient will never be stable. So I start range of motion on all my joint replacements on day 1. So because I want to get function back and movement back, if you don't move your patients after a joint replacement, they will stiffen up, and then your range of motion will never be good and your functional scores will never be good. So all my arthroplasties start range of motion day 1.
Okay. So I think the Chanakarn and Sang-Jin and Teru went out. So anyway, we should close the time to close this session. Thank you for joining this session, especially the audience. And thanks Jui from China, the speaker Chanakarn and Sang-Jin. Oh, Chanakarn there. And Teru, Well,
Everyone's here.
good. Well, Teru, everybody is here. Thank you so much. We enjoy your speech. Thank you, Jane, and thank you, John. I think he prepared the dinner party and some drink for us.
Dinner will be delivered to you online. Okay.
Yeah, I wish.
Okay. Thank you. We have to
Thank
say
you.
goodbye. Yeah, have a good day.
Thank you very
Thank
much.
you, Professor Lee, and everyone.
Thank you very much for all for speakers and to moderators. And you never disappoint us. Thank you very much. Dr. Tewi, can you please share the screen? Next one, please. Yes, we have a QR code for our audience who joined this webinar. Please join to our website and mark the point whether you are happy with this our webinar. This master course was not very beginners or registrar level lecture. It was really a master course, and I'm very happy that our experts have the same, difficulties and concerns for their practice. Thank you very much for sharing your experience with us. We had today, the webinar remind me a word of Dr. William Osler. Medicine is truly a science of uncertainty. We still need to learn a lot from what we are doing, and art of probability. So hopefully we can learn more from the clinical results from now on. So ladies and gentlemen, thank you very much for joining us. And lastly, not the least, I would like to share this slide with you all. APOA Hand Upper Limb Society is going to open inaugural meeting on 30th June and 1st of July in Seoul. So as a Congress chair, I'd like to welcome all of you to Seoul for this meeting. And we are going to have a very exciting program of shoulder arthroplasty to microsurgery so that you can learn a lot from this meeting. So thank you very much. If you are interested, you can get more information, and please submit your scientific papers and experience so that we can have a grand festival in Seoul. Thank you very much for joining. Thank you.
Thank you. See you, everybody. Thank you so much.